Welcome back to the deep dive. Today we are going to completely change the way you think about bacterial movement.
We really are.
Because, usually when we talk about bacteria, we picture them as these passive little spheres or rods, right? Maybe they're tumbling around or just drifting in the fluid current.
Right, sort of floating along.
But today we are dealing with the drills.
The stealthy spirals.
Yes.
It sounds like a covert ops team, and honestly, biologically speaking, that is exactly what they are.
We are tackling the spirochetes. This is a deep dive into Chapter 32 in Murray's Medical Microbiology. And we're also pulling some really distinct structural mechanics from Chapter 24 in jouts. And I have to say, looking at the research before we started these things, Treponema, Borrelia, and Leptospira, they are just terrifyingly elegant.
Elegant is the perfect word for it. They represent this completely different evolutionary approach to infection. Well, think about most bacteria. They rely on brute force.
Right.
They produce powerful toxins, or they just rely on overwhelming numbers to swamp the immune system. But spirochetes, they rely on motility and invisibility.
Stealth and speed. So let's set the stage with the cast of characters for you listening. We have three main antagonists today. First, we have the great pretender, Treponema pallidum, which is the agent of syphilis.
Right.
Second is the shapeshifter, Borrelia, which gives us Lyme disease and relapsing fever. And third, the water hazard, Leptospira.
And while they cause very, very different diseases, we were talking everything from sexually transmitted ulcers to tick-borne fevers to kidney failure from rat urine, they all share this unique structural blueprint that makes them so incredibly successful.
Let's get into that structural concept immediately because that's the foundation of everything we're going to talk about.
Yeah.
Murray describes the order spirochetes. Visually, these are thin helical bacteria. They are technically gram-negative, but as we'll see, the gram stain is basically useless for them.
Completely useless for most of them, yeah.
But the thing that really blew my mind looking at the Jowett supplement is the engine. These things do not have tails.
Right. If you think of a standard bacterium, something like E. coli or Salmonella, they have external flagella.
Like little whips.
Exactly. Imagine a boat with an outboard motor on the back. The propeller spins in the water, and the boat moves forward. And that works great if you are in a purely liquid environment, like a glass of water or the bloodstream.
But the human body isn't just a glass of water. It's mucus. It's dense connective tissue. It is highly viscous.
Yes, and an outboard motor is absolutely terrible in mud or thick gel. It gets tangled. It just lacks the torque to push through.
It gets stuck.
Right. Spirochetes solve this problem. They move the motor inside the ship.
This is the axial filament, right? Or the endoflagella.
Yes. So the flagella are rooted at the ends of the bacteria, but instead of sticking out into the environment, they wrap around the body of the cell. They are located inside the periplasmic space.
So that's between the inner cell wall and the outer membrane. I love the metaphor we were discussing before we started recording. Imagine the bacterium is wearing a really tight spandex suit.
It's the best way to picture it. That spandex suit is the outer membrane. The motors are underneath the suit, wrapped tightly around the torso of the cell.
So when those internal motors spin, they don't just paddle the water.
No, they force the entire flexible body of the bacterium to rotate. The whole organism spins. It corkscrews.
Which literally turns them into a drill.
Precisely. This structural setup allows them to generate incredible torque. So while other bacteria are getting bogged down and stuck in the heavy mucus layer of the gut or trapped in the connective tissue of the skin, the spirochete just bores its way right through.
It tunnels.
It tunnels through tissue that is entirely impenetrable to other organisms.
And that really is the mission statement for this deep dive. For you listening, we aren't just memorizing bugs today. We are looking at how this specific mechanical advantage, this drill, directly leads to the clinical patterns you will see in your patients or on your exams.
And we are going to see how that physical stealth allows them to hide from the host immune system for years, even decades.
Let's start with the most famous one, or perhaps the most infamous, Treponema pallidum, syphilis.
The great pretender.
It's called that because it mimics so many other diseases, right? But let's look at the organism itself first. You mentioned the gram stain earlier and how it's a trap here.
It is a classic exam trap and a very real clinical pitfall. Treponema is incredibly thin. We are talking about 0.1 to 0.2 micrometers wide.
That's microscopic even for bacteria.
Exactly. A standard gram stain involves adding dye, then washing it, then adding more dye. Treponema is just too thin to hold that stain. It's even too thin to be resolved clearly by the light of a standard microscope. You look through the lens and you see absolutely nothing.
So if you have a patient with a suspicious lesion, you swab it, you send it down to the lab, and the lab report comes back saying no organisms seen. But the patient actually does have syphilis.
Correct. Which is why, if you clinically suspect primary syphilis, you do not order a gram stain. You need dark field microscopy or a direct fluorescent antibody test, a DFA.
Dark field is such a cool technique. I always think of it like seeing dust motes in a sunbeam.
That is exactly the physics of it.
Yeah.
You block the direct light from hitting the slide, and you only allow oblique light to hit the sample from the sides.
So the background is pitch black.
Pitch black. And the light scatters off the edges of the spirochetes. They light up like these glowing silver corkscrews against a night sky.
But there is a massive catch to this, right? You have to do it immediately.
Yes, you have to do it on fresh exudate. If the sample dries out while sitting on a desk, the spirochetes die. They stop moving. And without that characteristic corkscrew motion, they are incredibly hard to positively identify among all the other cellular debris.
Speaking of them dying easily, Murray describes Treponema as metabolically crippled, or I don't know, maybe lazy is the better word.
Lazy kind of implies a choice. I would call it minimalist, extreme minimalism. This bacterium has a tiny genome. It lacks a tricarboxylic acid cycle. No TCA cycle.
Wow.
Right. It has no electron transport chain for oxidative phosphorylation. It cannot synthesize its own purines or pyrimidines, which are the fundamental building blocks of DNA and RNA.
So it's a total mooch. It can't make its own energy efficiently, and it can't even make its own building blocks.
It's an obligate parasite in the absolute truest sense of the word. It relies entirely on the human host to provide everything. It steals nucleotides. It steals amino acids.
There is a really interesting evolutionary argument here, though. Is this primitive, or is this actually highly advanced?
That is the ghost in the machine theory. Think about it. By stripping away all these metabolic pathways, the bacterium becomes less visible.
Because every enzyme is a target.
Exactly. Every enzyme you produce is a potential antigen for the host's immune system to recognize and attack. If you simply don't make the enzyme, the immune system can't target it. So shedding genes is actually a brilliant form of stealth.
It's like throwing all your cargo off the ship to make it lighter and faster and harder to track. But this metabolic dependency also explains why you cannot culture it in the lab.
This is a huge takeaway for students. You cannot grow Treponema pallidum on a standard blood agar plate or a McConkey plate. It will not grow. If an exam question gives you a scenario and asks you to culture the lesion for a diagnosis of syphilis, that is always the wrong answer.
It also perfectly explains why it is so fragile environmentally.
Right. It is microaerophilic. It hates high oxygen levels because it lacks the enzymes like catalase and superoxide dismutase that would protect it from oxygen toxicity. And as we said, it dies rapidly upon drying.
Which brings us to the myth-busting portion of the deep dive, the infamous toilet seat.
The classic excuse. I got syphilis from a public toilet seat.
Biologically, is that even possible?
It is virtually impossible because the bacteria would dry out and die within seconds to maybe minutes on a cold, dry surface. Transmission requires direct, intimate contact with an active, moist lesion, and that usually means mucous membrane to mucous membrane contact.
So the routes are sexual transmission, congenital transmission across the placenta from mother to fetus, or through a blood transfusion. Those are really the only ways.
Exactly. Humans are the only natural host. There's no animal reservoir out in the wild for Treponema pallidum.
Let's move to the stealth aspect of the pathogenesis. We established it acts like a drill to get in, but it also weighs a disguise once it's there. Murray talks about the outer membrane having a very low density of exposed proteins.
We call this the Teflon coat. The human immune system works by recognizing antigens, which are usually structural proteins on the surface of a bacterium. Treponema has almost no surface proteins exposed to the outside environment. It is incredibly smooth.
So there's nothing to grab.
Right. There are no handles for our antibodies to grab onto.
And it doesn't just lack handles, it actively covers itself in our stuff.
Fibronectin. That is a human host protein involved in tissue adhesion and wound healing. Treponema expresses a fibronectin binding protein that essentially coats the bacteria in the host's own molecules.
It's wearing a human suit.
It's wearing a human suit. So a macrophage comes along, bumps into the spirochete, feels the fibronectin, and says, oh, excuse me, you're just a piece of human connective tissue, and it just moves on.
Meanwhile, the spirochete is using an enzyme called hyaluronidase to hack through the actual connective tissue.
The machete.
Right, the machete.
Hyaluronic acid is the glue that holds our cells together in the extracellular matrix. Hyaluronidase dissolves that glue. This is what allows the spirochete to slip between cells and infiltrate the perovascular spaces, the areas right around the blood vessels.
Now, despite all this tissue invasion, Murray makes a critical point here. Treponema doesn't actually produce any major toxins. It's not like tetanus or cholera.
No exotoxins, no massive endotoxin release.
So why does it eventually destroy your face, your heart, and your brain?
Because of us. The tissue damage is almost entirely caused by the host's own immune response.
Wow.
It is a delayed type hypersensitivity reaction. The body eventually realizes the bacteria are hiding in there, and it launches a massive, chronic, granulomatous inflammatory response.
So we destroy ourselves trying to get to it.
Exactly. It's the prolonged inflammation that eats holes in the bone, which we call gummas, or destroys the lining of the aorta. The bacteria essentially baits the immune system into burning down our own house.
That is horrifying. Let's walk through the clinical play then. Syphilis is almost always described in acts. Let's start with Act 1, primary syphilis.
The chancre. This occurs exactly at the site of inoculation, usually anywhere from 10 to 90 days after the initial exposure. The bacteria multiply locally at that spot, and you get a small papule that eventually erodes into a distinct ulcer.
And here is the single most important clinical differentiator for exams and real life. Is this ulcer painful?
No, that is the hallmark. A syphilitic chancre is a painless ulcer with raised, indurated hard borders. We call it a hard chancre.
I always try to anchor this by contrasting it with Haemophilus ducreyi.
Right. Haemophilus ducreyi causes chancroid, which is a very painful ulcer. The mnemonic everyone uses in med school is you do cry with ducreyi. Syphilis, on the other hand, is the silent, painless ulcer.
Mechanistically, why is it painless? Why doesn't an open sore hurt?
It's likely because the spirochetes invasion is perovascular. It causes an obliterative endarteritis blocking small blood vessels, and it doesn't initially destroy the local nerve endings in the same acute, highly necrotic way that ducreyi or the herpes virus does. It's a much cleaner, stealthier invasion.
And what happens if the patient ignores it and does nothing?
It heals spontaneously.
See, this is the deceptive part. This is where it tricks you.
It is the perfect trap. The patient sees a weird sore. They might freak out a bit, but because it doesn't hurt, they decide to wait and see. Then 3 or 6 weeks later, it just vanishes. And they think, oh, I guess I'm fine. It was just a weird irritation or an ingrown hair.
But they're definitely not fine.
Not at all. The local factory has closed, but the product has already been shipped. The spirochetes have entered the bloodstream and the lymphatics. They are actively disseminating to every organ in the body.
Enter Act 2, secondary syphilis.
The dissemination phase. This usually happens weeks to maybe a few months after that primary chancre heals. The patient develops a very nonspecific flu-like syndrome. Fever, sore throat, headache, and generalized lymphadenopathy, swollen lymph nodes everywhere.
And then the rash.
The classic rash. It's a generalized mucocutaneous rash. But the key exam, finding the thing that should make your clinical alarm bells ring immediately, is that it covers the palms of the hands and the soles of the feet.
Because very few rashes actually do that.
It's a very short differential list. Rocky Mountain spotted fever, Coxsackie, a virus which causes hand, foot, and mouth disease, and syphilis. If you see a maculopapular rash on the palms and soles of an adult, you absolutely have to rule out secondary syphilis.
Are these skin lesions contagious at this stage?
Highly contagious, especially the ones that form in moist areas of the body. We call those condylomata lata.
What do those look like?
They're these wart-like, raised, grayish-white moist lesions usually found in the groin or the armpit folds, and they are absolutely teeming with live spirochetes.
Okay, so primary is a local painless ulcer. Secondary is systemic spread with a highly infectious rash. And then it goes quiet again.
The intermission, we call this latent syphilis. Eventually, the immune system produces enough antibodies to suppress that massive bloodstream infection. The visible symptoms resolve. The patient feels completely normal again.
But the bacteria are still there.
They are hiding deep in the tissues, growing incredibly slowly. This latent period can last for years. It can last for decades.
Until we reach Act 3, the destruction, tertiary syphilis.
This is where that bystander damage we talked about earlier really manifests. It affects roughly a third of untreated patients. This is where you see the gummas.
Gummas sound like something you'd buy in a candy shop, but they definitely are not sweet.
They are terrible. They are granulomatous lesions. Basically, these rubbery, necrotic, destructive masses that can form anywhere in the skin, in the bone, or in the liver. It's the body trying desperately to wall off the remaining bacteria, but it ends up destroying the surrounding tissue in the process.
And what about the cardiovascular system? Murray emphasizes that.
This is fascinating pathology. The spirochetes specifically invoke an inflammation of the vasa vasorum.
Which translates to the vessels of the vessels.
Right. The aorta is a massive, thick, high-pressure tube. Its walls are so thick that it needs its own dedicated blood supply to feed the outer muscle layers. Those tiny blood vessels feeding the aorta are the vasa vasorum. Syphilis causes an obliterative endarteritis. It chokes off those tiny supply vessels.
So the wall of the aorta starves.
It starves and it weakens.
And when a high-pressure pipe weakens?
It dilates. You get an aneurysm, specifically an aneurysm of the ascending aorta, and the chronic scarring leads to this classic tree-barking appearance on the inside of the aorta. It literally looks like wrinkled tree bark.
And finally, the brain. Neurosyphilis.
This presents classically as Tabes dorsalis and general paresis. Tabes dorsalis is the slow degeneration of the dorsal columns of the spinal cord.
That's the part that handles proprioception, right? Knowing where your body is in space.
Exactly. Patients lose their proprioception. They don't know where their feet are without looking at them. So they develop a very specific wide-based slapping gait, just trying to feel the floor. And they have a positive Romberg sign.
And general paresis.
That's the direct involvement of the brain parenchymy itself. It causes severe personality changes, dementia, mania, delusions of grandiosity. Actually, in the pre-antibiotic era, a huge percentage of patients admitted to psychiatric asylums actually just had tertiary neurosyphilis.
Now, Murray puts a very big warning sign right here regarding HIV patients.
Yes. In modern medicine, we cannot think of neurosyphilis strictly as a tertiary or late-stage complication anymore. In patients who are co-infected with HIV, neurosyphilis can occur much, much earlier, even during the secondary stage. The severe immune suppression accelerates the spirochetes invasion of the central nervous system.
Before we move on to how we diagnose all of this, we have to mention congenital syphilis.
This is an absolute tragedy because it is entirely preventable with proper prenatal care. It's the transplacental transmission of the bacteria from an infected mother to the fetus.
What does it look like clinically?
If the baby is born with an active infection, you typically see something called snuffles. It's this extremely thick, highly infectious, purulent nasal discharge. And they often have a widespread, peeling, desquamating rash.
And if they survive that initial phase but remain untreated?
Then you see the permanent developmental scars later in childhood. Things like Hutchinson's teeth, where the central incisors are notched, almost like a saw blade. Mulberry molars, where the back teeth have too many cusps. Saddle nose deformity due to the destruction of nasal cartilage. And saber shins, where the tibia bone bows sharply forward like a curved sword.
It's a very distinct, tragic pattern. Okay, let's get into the exam high-yield zone, diagnosis. This trips up absolutely everyone because there are two completely different types of blood tests.
The net and the spear. You really need to build a mental model to understand the difference between non-treponemal tests and treponemal tests.
Let's start with the net, the non-treponemal tests. These are the VDRL and the RPR.
These are your screening tests. They're cheap, they are fast, and they are easy to run. But here's the mind bender for a lot of students. These tests do not detect the syphilis bacteria. They don't even detect bacterial parts.
They detect ragin. What on earth is ragin?
Ragin is a host antibody. It's a mixture of IgM and IgG that specifically binds to something called cardiolipin.
And cardiolipin is lip.
It's a lipid that is normally found inside mitochondrial membranes. When cells are damaged and destroyed, either the host's own cells or the bacterial cells, this lipid is released into the bloodstream.
So the VDRL is effectively just a tissue damage detector.
Exactly. It is a smoke detector. It goes off if there is a massive fire, like a syphilis infection, but it also goes off if you just burn toast.
And the burnt toast in this analogy represents false positives.
Yes. Any condition that causes significant cellular damage or severe immune dysregulation can trigger it. Viral infections like mono or hepatitis, certain drugs, rheumatic fever, lupus, even normal pregnancy. The classic mnemonic for false positives is literally VDRL: viral, drugs, rheumatic fever, lupus, and leprosy. If a patient has severe lupus, they might have a positive RPR test, even if they have never encountered syphilis in their entire life.
So if it's that nonspecific, why do we even use it?
Because it is quantitative.
Yeah.
You can measure the exact titer or concentration. When you successfully treat syphilis, the tissue damage stops, the fire goes out, the smoke clears, so the RPR titers will visibly drop. It is the absolute best way to track if your antibiotic treatment is actually working.
Okay, so if the smoke detector goes off, we need to confirm that there's actually a fire, not just burnt toast. We need the spear the treponemal tests.
These are tests like the GPPA, the FTA-ABS, or the EIA. These use actual Treponema pallidum antigens in the assay. They're highly specific. If this test is positive, it's not lupus. It is definitively syphilis.
But you cannot use them to track treatment progress.
No, you can't. Because once your immune system forms specific antibodies to Treponema, you keep those antibodies for life. The test remains positive even decades after you were completely cured. We call it the serological scar.
Let's run a quick scenario. Patient comes in, their RPR screening test is positive. You order a TPPA confirmatory test, and it is negative.
That is a false positive RPR. It's likely a viral infection or maybe an underlying autoimmune issue, but it is not syphilis.
Okay, scenario 2. RPR is negative, but the TPPA is positive.
Two possibilities here. Either it's extremely early primary syphilis, meaning they have the chancre, but the tissue damage hasn't produced enough reagent for the RPR to rise yet, or, much more likely, it is a previous, successfully treated syphilis infection. They have the lifelong scar from the TPPA, but there is no active smoke for the RPR.
That makes it so much clearer. Let's talk treatment. We actually have a magic bullet for this one.
We do. Penicillin G. Specifically benzathine penicillin G, which is the thick, long-acting intramuscular form. You give it as a shot in the glutes.
It's incredible to me that after almost a century, Treponema has not developed resistance to penicillin.
It goes right back to that lazy minimalist genome we talked about. It doesn't have extra plasmids. It doesn't have transposable genetic elements. It has no molecular mechanism to import or share resistance genes with other bacteria.
Yeah.
It is evolutionarily stuck in a time capsule. Penicillin works just as well today as it did in 1945.
What if the patient is allergic to penicillin?
You can use doxycycline for primary or secondary syphilis, but, and this is a massive, but for clinical practice, if the patient is pregnant or if they have neurosyphilis, doxycycline is not good enough. It won't cross the placenta reliably, and it doesn't penetrate the central nervous system well enough.
So what do you do if a pregnant woman with syphilis has a severe penicillin allergy?
You desensitize her. You admit her to the hospital, usually the ICU, and you give her microscopic, slowly increasing doses of oral penicillin until her immune system tolerates it. You absolutely must use penicillin in those specific cases to protect the fetus.
Finally, for this section, we need to cover the Jarisch-Herxheimer reaction.
This is a very dramatic clinical event.
Oh.
You diagnose the syphilis, you inject the penicillin, the patient feels fine. But 2 to 4 hours later, they start shaking violently. High fever, chills, hypotension, severe muscle aches. They look like they're rapidly going into shock.
The floor nurse calls you in a panic and says, "Doctor, the patient is having an anaphylactic allergic reaction to the penicillin."
And you have to say, no, they aren't. A true IgE-mediated allergic reaction would look like hives, wheezing, throat swelling, true anaphylaxis. This is different. This is a cytokine storm.
What is actually happening inside the patient's body?
The penicillin has just effectively blown up billions of spirochetes all at the exact same time. They are lysing, and they are releasing all that interlipoprotein, all that hidden antigenic material we talked about earlier, directly into the bloodstream. The immune system, which couldn't see them clearly before because of the Teflon coat, suddenly sees everything at once, and it panics. It dumps massive amounts of TNF-alpha and interleukin-6.
It's the explosive death throes of the bacteria?
Exactly. It's actually a clinical sign that your antibiotic treatment is working perfectly. You do not stop the drug. You give IV fluids, Tylenol, and reassurance. The whole reaction usually passes safely within 24 hours.
All right, that thoroughly covers the Great Pretender. Let's shift gears now to the shapeshifter, Borrelia.
Borrelia is a fascinating genus that gives us two major clinical entities, Lyme disease and relapsing fever.
First off, just visually under the microscope, how does Borrelia differ from Treponema?
It is significantly bigger. It's much thicker. Remember we said Treponema is too thin for standard stains? Borrelia is like a bodybuilder by comparison. You actually can see it with aniline dyes, like a Gemsa stain or a Wright stain.
That's a key distinction. You can actually see these directly on a standard blood smear, especially when we talk about relapsing fever.
Correct. You don't always need dark field for Borrelia.
Let's start with the big one, though, Lyme disease. Borrelia burgdorferi.
By far the most common vector-borne disease in the United States.
The vector is the tick. But the specific details really matter here for exams.
It has to be the hard tick. The genus is Ixodes, specifically Ixodes scapularis in the northeast and Midwest, and Ixodes pacificus out on the west coast.
The life cycle of this tick is essentially a relay race involving 3 different runners, the larva, the nymph, and the adult.
And the baton they are passing between them is the Borrelia bacteria. So the larva hatches in the spring, and it feeds on the white-footed mouse. The mouse is the primary natural reservoir. It carries high loads the bacteria in its blood, but it doesn't get sick.
The larva picks up the bacteria from the mouse, it molts over the winter, and it becomes a nymph.
The nymph is the true assassin here. It is incredibly tiny, about the size of a poppy seed. It feeds on larger mammals, including humans, usually in the early summer. Because it is so unimaginably small, you don't feel the bite, and you almost never see it hiding in your hairline or behind your knee. That is why 90% of documented human Lyme cases come specifically from the nymph stage.
And then it feeds, drops off, molts, and becomes an adult, which feeds on the white-tailed deer.
Right. And the deer is really just the mating ground for the adult ticks. The deer itself doesn't actually carry the Borrelia bacteria effectively, but it's crucial because it supports the overall tick population density in the forest.
Now, I want to spend some time on the outfit change. Murray describes this genetic switch in surface proteins, and I just found it mind-blowing. This is the definition of a smart pathogen.
This is the OspA to OspC switch. It is pure, elegant, evolutionary genius.
Set the scene for us. The bacteria is just sitting there in the cold gut of a tick.
Right. The tick is wading the grass. The bacteria inside its midgut is starving, it's dormant, and it is holding on for dear life so it doesn't just get excreted. To do this, it expresses a surface protein called OspA, outer surface protein A. OspA acts literally like a Velcro hook, firmly anchoring the bacteria to the wall of the tick's gut.
Then the tick brushes onto a hiker, it finds a spot, and it bites. Warm mammalian blood starts rushing into the gut.
The bacteria instantly senses two things: the rapid rise in temperature going from ambient forest temp up to 37 degrees Celsius, and the sudden influx of rich blood nutrients. This triggers a massive genetic switch.
It's like an alarm going off. Wake up, we're moving.
Exactly. They immediately shut down the gene-making OspA. They let go of the gut wall, and they start rapidly synthesizing a new protein, OspC.
What does OspC do for them?
OspC is the invasion protein. It allows them to migrate out of the midgut, travel through the tick's hemolymph into the salivary glands, and it prepares them to survive the initial immune response once they enter the human bloodstream.
But this complex wardrobe change takes time.
It is not instantaneous. It takes roughly 36 to 48 hours of continuous feeding for the bacteria to completely detach, swap their surface proteins, migrate to the saliva, and enter the human host.
This is probably the single most practical piece of medical advice in the entire chapter.
It really is. If you go hiking and you find a tick on you and it is flat, or you know for a fact it's been attached for less than 24 hours, you are generally safe. You do not have Lyme disease. The bacteria physically has not had enough time to make the switch and travel to the saliva. You just pull it off and wash the bite.
But if the tick is swollen and engorged with blood,
then the risk is very real,
Yeah.
and we consider prophylactic antibiotics.
let's say the bacteria makes it in. What are the clinical stages of Lyme?
Stage 1 is early localized disease. The hallmark is the bullseye rash, erythema migrans.
It's a flat red macule that slowly expands outward, usually with a distinct clearing in the center.
It looks exactly like a target, and what you are actually seeing is the leading edge of the spirochetes physically swimming through the skin tissue. They are migrating away from the bite site in an expanding circle.
Now, as a clinician, do you treat this strictly based on how it looks?
Yes, absolutely. If you live in an endemic area and you see erythema migrans, you prescribe antibiotics immediately. You do not wait for lab confirmation. Serology is almost always negative in this early stage because the human body hasn't had time to mount a measurable antibody response yet.
Stage 2, early disseminated Lyme.
This happens weeks to maybe months later. The spirochetes are now in the blood and deep tissues. The classic triad you need to memorize for stage 2 is 1, facial nerve palsy, like Bell's palsy, which is often bilateral, a huge clue because bilateral facial palsy is rare for other causes. 2, cardiac involvement, specifically an AV block, which can cause fainting or palpitations. And 3, migratory arthralgia, joint pain that moves from knee to shoulder to ankle.
And if that is missed, we hit stage 3, late Lyme disease.
This is months to years later. The main feature is severe chronic arthritis, classically involving a single large joint, like one heavily swollen knee. It's caused by the immune response creating a chronic destructive synovitis in the joint space.
Diagnosis for Lyme involves a very specific two-step process, right?
Yes, the 2-tier testing algorithm. First, you run a highly sensitive screening test, usually an ELISA or IFA. If that comes back positive, you must confirm it with a highly specific Western blot. This 2-step process prevents false positives from other cross-reacting antibodies. But again, in the early rash stage, clinical diagnosis rules.
The treatment.
doxycycline. It is the absolute workhorse for tick-borne diseases. If it's a young child under 8 or a pregnant woman, you use amoxicillin to avoid the bone and teeth side effects of doxycycline. And if there is severe neurologic or cardiac involvement like meningitis or a severe AV block, you step up to IV ceftriaxone.
Let's pivot to the other Borrelia disease, relapsing fever. Honestly, the mechanism for this one feels like the plot of a sci-fi movie.
The shapeshifter name really comes from this specific organism. Relapsing fever is caused by Borrelia recurrentis, which is louse-borne, or other Borrelia species, which are tick-borne.
Can you break down the epidemic versus endemic forms?
Sure. The epidemic form is louse-borne. It's caused by Borrelia recurrentis, carried by the human body louse. Humans are the only reservoir. This usually explodes in situations of war, refugees, or severe overcrowding. The interesting thing is, the louse doesn't inject it when it bites. You only get infected when you crush the infected louse into your own scratched skin.
Gross, but effective. And the endemic form?
That's tick-borne. It's carried by a soft tick genus Ornithodorus. These ticks live in rodent burrows, or the walls of rustic, rat-infested cabins, especially in the western U.S. They come out at night, bite you incredibly fast, like in 15 minutes, and detach. You never even know they were there.
Let's talk about the mechanism of the relapse itself, antigenic variation. Can you explain the cat and mouse game happening in the bloodstream here?
It's amazing. So, you get infected, the bacteria multiply, and you spike a massive fever. Your immune system wakes up, sees the bacteria's surface protein, call it code A. The immune system rapidly manufactures anti-antibodies.
And the immune system attacks.
It slaughters them. 99.9% of the bacteria with code A are destroyed. The fever breaks, the patient sweats, cools down, and feels much better. But hidden deep in that initial population was maybe one single bacterium that spontaneously rearranged its plasmid DNA to express a completely different surface protein code.
So the anti-A antibodies floating around just bump into it and float right past.
Exactly. Bacteria B is effectively invisible to the current immune response. So while the patient thinks they are cured, bacteria B is multiplying. A week later, you have 1 billion bacteria Bs in the blood. The massive fever spikes again.
The immune system wakes up again. Wait, who are these guys?
Right. It starts the whole process over. It makes anti-B antibodies. It clears the infection. The fever breaks. But by then, one sneaky survivor has already switched to code C.
How many times can this cycle repeat?
Usually 3 to 10 distinct relapses. It only stops when the bacteria finally exhausts its genetic repertoire of variant coats, or, thankfully, when the patient gets appropriate antibiotics.
And the diagnosis here is quite unique compared to the others because during the fever spikes, the bacteremia is so incredibly massive.
Yes. Unlike Lyme or syphilis, where the bugs are scarce in the blood, and relapsing fever, if you draw the patient's blood right during the febrile spike, you can literally see the Borrelia spirals on a simple gym-sustained blood smear. It's a very dramatic, definitive finding.
Treatment.
Doxycycline again. Like I said, it is the anti-spirochete drug of choice across the board. Or penicillin or macrolides if doxy is contraindicated.
All right, final character in our cast today, the water hazard.
Leptospira.
Leptospira interrogans.
I love that species name, interrogans.
It's named that because of how it looks. It's a very tight spiral, but the ends are sharply hooked. Under the microscope, it looks exactly like a shepherd's crook or a question mark, hence interrogans.
This bug is an obligate aerobe, unlike Treponema, and its entire life cycle is intimately tied to water and animals. It is a classic zoonosis. The natural reservoir is rodents, especially rats as well as dogs, and farm animals like cattle and pigs. The bacteria establish a chronic asymptomatic infection, specifically in the renal tubules, the kidney pipes of these animals.
So the animals are constantly peeing the bacteria into the environment.
Constantly. They shed massive amounts of Leptospira in their urine, and if that infected urine hits a freshwater puddle, slow-moving river, or damp soil, the bacteria can survive out there for weeks or even months.
So, clinically, who is the classic patient?
The classic board question is usually a surfer in Hawaii or a triathlete who just competed in a freshwater lake swim, or maybe a sewer worker or a farmer cleaning out outbuildings. Anyone with recent exposure to water or mud contaminated by animal urine.
How does it actually get into the human body?
It is highly invasive. It's thin and motile enough to penetrate intact mucous membranes, like the conjunctiva of the eyes or the lining of the mouth, or it can go through tiny microscopic abrasions in the skin. So if you swallow a mouthful of lake water, or if you have a tiny scratch on your calf while wading in a rice paddy, it just drills right in.
Once it's in the bloodstream, what is its primary target?
It targets the endothelial cells lining the blood vessels. It causes a systemic small vessel vasculitis.
The clinical course for leptospirosis is biphasic, right? Two distinct phases.
Yes, phase 1 is the septicemic phase. The bacteria are multiplying in the blood and CSS. It hits you with a sudden, severe flu-like illness. High fever, chills, and horrible, debilitating muscle aches, specifically localized to the calves and the lower back. And it produces a very key physical sign, conjunctival suffusion.
Which is really just fancy medical speak for red eyes, right?
Yes, but distinct red eyes. Unlike viral pink eye, there is no pus. There is no crusty exudate. It is just extremely angry, dilated, bright red blood vessels in the whites of the eyes.
Then the fever drops. The patient thinks they're getting better.
But then phase 2 hits. The immune phase.
Yeah.
The spirochetes are cleared from the blood as IgM antibodies appear, but now the immune complexes cause secondary damage. You get aseptic meningitis, and the bacteria settle into the patient's kidneys, so they start shedding it in their own urine.
And in the most severe cases, this progresses to something called wild disease.
Wild disease is the severe icteric form of leptospirosis. It has a high mortality rate.
What defines it clinically?
It's a classic triad.
Oh.
1, profound liver dysfunction causing deep jaundice. The patient turns bright yellow. 2, severe kidney failure causing azotemia and lack of urine output. And 3, massive hemorrhage, bleeding into the lungs or gut due to vascular damage and very low platelets.
So if you have a patient who was swimming in a muddy lake 2 weeks ago and now they are suddenly turning yellow and their kidneys are shutting down.
You must immediately think of leptospirosis.
Diagnosis for this one seems a bit tricky.
It is. Culturing it requires special media like EMJH, and it takes weeks or months. It's too slow for clinical use. So we rely on serology. The absolute gold standard is the microscopic agglutination test, or EMIT, but it's very complex and usually only done at reference labs.
And treatment.
If you catch it early and it's mild, oral doxycycline. If it progresses to severe wheal disease, you must admit them and hit them with high-dose IV penicillin or ceftriaxone.
Okay, we have drilled deep, pun absolutely intended, into all three of these organisms. We've covered a massive amount of ground. Let's integrate this knowledge. I want to throw some rapid scenarios at you. We'll call this clinical rounds. I will give you the patient presentation and you tell me what is happening and why.
I love it. Let's do it.
Case 1. A 24-year-old male comes into the clinic with a painless ulcer on his penis. He says it showed up about 3 days ago. You do a rapid RPR test right there in the office and it comes back negative. He is relieved and asks if he's totally clear.
He is absolutely not clear. Because the RPR, which is the net, takes time to become positive. It often takes weeks after the initial infection because it relies on cumulative tissue damage and the slow formation of region antibodies. He is in the window period. The clinical finding of a painless genital ulcer is highly suspicious for primary syphilis. You need to treat him presumptively right now or order a specific treponema test, the SPEAR, or use dark field microscopy if you have it. Do not trust a negative RPR in the first few days of a chancre.
Excellent. Case 2. A 7-year-old boy from Connecticut comes into the ER with facial droop on the left side of his face. His mom says he had a generic summer flu a few weeks ago, but she swears she never saw any kind of rash.
This is Lyme disease, specifically the early disseminated stage.
Break down the clues.
Well, Connecticut is highly endemic for Ixodes ticks. An isolated facial droop, Bell's palsy, in a child in the summer is a classic stage 2 finding. The summer flu was likely the initial systemic infection. As for the missing rash, erythema migrans is actually completely missed by patients in up to 20 to 30% of cases. Either didn't form cleanly or it was hiding in his scalp or on his back where mom just didn't see it. You treat this child with amoxicillin.
Case 3. A camper who is just hiking in the Rocky Mountains wakes up with a high fever. It breaks after 3 days. He feels fine. 5 days later, the exact same fever comes back. He remembers pulling a tick off his leg in a rustic cabin, but he says it was soft and leathery, not hard like a normal dog tick.
That is endemic relapsing fever.
From the tick's description.
Exactly. The soft tick, orthodoros, is the specific vector for tick-borne relapsing fever in the western U.S. cabins. The cycling, repeating fever is due to the antigenic variation of the Borrelia's surface proteins. If you smear his blood right now during this second fever spike, you will likely see the spirochetes under the microscope.
Case 4. A patient is currently being treated in your clinic for syphilis. 2 hours after you give them the penicillin G shot, they suddenly develop violent rigors, chills, and a temperature of 103 degrees. The floor nurse is grabbing the epinephrine syringe for anaphylaxis.
Stop the nurse immediately. Do not give epi. This is the Jerish-Herxheimer reaction.
Walk us through the why again.
The timing is the key. It's 2 hours post-dose. And the symptoms are fever and rigors, not the classic wheezing, lip swelling, or hives of an Ig-mediated allergy. This is a massive cytokine storm caused by the sudden lysis of billions of spirochetes releasing their internal antigens all at once. It means the drug is working. You provide supportive care with fluids and antipyretics, and it will pass.
Perfect. Final case, case 5. A 30-year-old triathlete presents to the ER with orange skin, meaning deep jaundice, and he hasn't urinated in 24 hours. His labs show severe renal failure and extremely low platelets.
That is wild disease, severe leptospirosis.
The triad.
Right. The combination of liver failure, causing the jaundice, plus kidney failure, causing the anuria, plus a hemorrhagic tendency from the low platelets, all in an athlete with recent freshwater exposure. It's the classic textbook presentation.
Fantastic. This brings us perfectly to the so what portion of the deep dive. Why does all of this actually matter structurally?
I think the big takeaway here is that evolution always finds a way. These organisms do not have the brute force of other bacteria. They don't build massive protective capsules. They don't drop toxic payloads to kill our cells. But they have absolutely mastered the dark art of movement and disguise.
Whether it's drilling straight through dense connective tissue with an internal motor, or changing their protein coat every week like a spy changing jackets to evade capture, or coating themselves in human fibronectin to hide in plain sight.
Exactly. They teach us that clinical infection isn't always just a loud, violent war of weapons and toxins. Sometimes the deadliest infections are a quiet war of information and stealth.
For everyone listening, if you want to lock this knowledge in for the long term, open up Murray chapter 32. I specifically want you to look at table 32.1 for the structural features we discussed, and table 32.3 for the syphilis testing algorithm. That net and spear table is absolutely essential for your board exams.
And while you're at it, just do a quick image search for erythema migrans. Once you see a high-quality photo of that expanding bullseye rash, you will never, ever forget it.
All right, before we go, we promised a quick rapid-fire recall session to test your attention. I'm going to ask 5 single best answer questions. I'll pause for a beat, you answer it in your head, and then we'll give you the solution. Ready?
Let's do it.
Question 1. Which specific spirochete can be easily visualized with a standard aniline dye, like a Gemsa or Wright stain? Think about it for a second.
The answer is Borrelia. Remember, Treponema is way too thin, and Leptospira usually requires serology or dark field. Borrelia is the bulky one.
Question 2. What is the specific target antigen that the VDRL screening test is looking for? Take a guess.
Cardiolipin. It's that lipid released from damaged host and bacterial mitochondrial membranes. It's the smoke from the fire.
Question 3. Which specific life stage of the Ixodes tick is most likely to actually transmit Lyme disease to a human?
Got it. The nymph stage. Because it is the size of a poppy seed, so it goes completely unnoticed and gets the full 48 hours needed to feed.
Question 4. What is the underlying mechanism that explains the painless nature of the syphilitic chancre, especially when compared to the painful chancroid of Haemophilus ducreyi? Think about the tissue damage.
Syphilis preserves the local nerve architecture initially. It causes a stealthy perovascular inflammation, whereas Haemophilus ducreyi causes massive, acute, highly destructive tissue necrosis that destroys the nerves.
Question 5, the final one. What is the drug of choice for a pregnant woman diagnosed with early localized Lyme disease? Careful on this one.
Amoxicillin. You cannot use the standard doxycycline because it is strictly contraindicated in pregnancy due to the severe effects on fetal bone and teeth development.
Nailed it. Well, thank you for diving so deep with us into the fascinating microscopic world of the stealthy spirals.
This was a great one. Stay safe out there. Always check yourselves for ticks after a hike, and we will see you for the next chapter.